in the clinical practice. Stroke, of course, incidence of the stroke is varying geographically. India comes under the area where somewhere the incidence is in the moderate range. It's more in the northern states, northern Russian and other areas, whereas India comes under the moderate. But still, the incidence is quite high as such, and it can occur in the younger age. Another important issue is that if at all you look at the age distribution, the age distribution of the stroke patients in India is comparatively lower. So younger age patients are more prone to develop the stroke. The real causes are not known, but that's one of the severe issue or serious issue, because younger age they would be more productive, and hence the impact on the quality of life due to the stroke is quite high. Now, instead of going into the other part of the theory, we'll directly go into the clinical aspects. Clinically, the stroke could be of three varieties: transient ischemic attack, progressive, complete, or static. Transient ischemic attack means when the patient would have a neurological deficit temporarily and the patient recovers within 24 hours. Most of the times, the cause for the transient ischemic attack is a hypertension. So it's not that always. It's the majority of the conditions. It's the hypertension. It could be the other causes also. Even a moderate hypoxia can produce a transient ischemic attack. Transient ischemic attack can be a precursor to many other serious illnesses. So a patient of transient ischemic attack, even if the patient has recovered completely within 24 hours, he needs to be investigated and corrective measures have to be taken. Progressive is where the patient comes to you immediately after the stroke and the condition is continuously progressing as such. I'll deal with that a bit more in detail. So once the patient has a stroke, some areas of the brain may get damaged, but surrounding area of that damaged area, the nerves will not be functioning, and this is one of the critical stage. So most of the times, the patients who come to the hospital immediately after the stroke, in the first 2 to 3 days, it's usually progressive. The duration of the progression can be varying, and so it's quite important to assess whether the patient is in a progressive stage or not. And a complete is where the stroke has occurred, the tissue is dead, it's only the neurological deficits which are residual, they are the issue of concern, and the patient has come to you for that reason. And usually, it's about 2 to 3 weeks after the stroke, you may reach that stage of complete stage. So the important is the critical phase of the treatment is the progressive stage where the condition tends to be progressive as such. And assessment and management at that stage is very critical. And that's one way of classifying the stroke as such. The other way, depending upon the pathology, the strokes could be of mainly two categories: ischemic and hemorrhagic. In addition to this, there are the other two types of strokes: toxic and pressure occupying or compression lesions, which are not very important types as such. Most commonly in the clinical practice, if you remember about that ischemic and hemorrhagic strokes, that's quite good enough. Ischemic strokes are those where there would be a hypoxia or reduced oxygen supply to the area of brain, and it could occur due to either a thrombosis. Thrombosis is a clot developing gradually in the vessels and the vessels get blocked. Embolism is a thrombus which has occurred somewhere else and then has floated into the vessel and then blocked them. And based upon that, the clinical course or the onset of the symptoms will be different. Thrombosis, it's gradually progressive. The clinical symptoms will occur gradually, and then it will be extended. So in the beginning, the symptoms would be lesser, area of involvement of the brain would be lesser, but then gradually it extends further. Most of the times, patients of thrombosis are old-aged patients. They have some atherosclerosis-like condition or hypertension also is a very common asset. Embolism patients, the onset would be sudden, but even though it is sudden, the symptoms may not be global, that in the sense the patient may not lose the consciousness as such. And once it has occurred, it doesn't extend rapidly, or unlike that of the thrombosis, there may not be an extension. Within a short duration, you may have that complete stage, the stage of complete stroke, and then the patient may start recovering. Most of the times, the patient would have a cause for the embolism, clot, and the most common cause is cardiac abnormalities. Patient may have a valvular defects or arrhythmias, which could be the cause for the clot, and the thrombus floating in is the issue. So, in a patient with embolism, it's quite important to assess the real cause for the embolism. The origin of the thrombus has to be evaluated. A thorough assessment of the cardiovascular system is absolutely essential. When I say this, I don't mean to say that in other conditions it's not important. In every patient, it's important, but in a patient with embolism, it's very critical. The cause for the thrombus has to be assessed. Then another type of stroke is hemorrhagic. Hemorrhagic is when a vessel gets either ruptured within the brain, that's the intracerebral, and once the blood leaks into the brain tissue, the brain tissue, nerve tissue, is not really conditioned to a direct exposure of the blood. The nourishment supply to the brain is a very unique feature. You have a blood-brain barrier. The nourishment passes through another separating membrane, and the fluid, only the selective fluid and nourishment is transmitted to the brain in the normal nerve tissues in the normal condition. If at all there is a hemorrhage and the nerve tissue come into the contact with the blood directly, that produces a widespread irritation of the nerves, and hence either the nerves may get dead or maybe even damaged partially. So in case of intracerebral hemorrhagic pathology, the onset is sudden, and most of the times there is some cause for the rupture of the vessel, and the cause for the rupture of the vessel could be either a hypertension or there could be vascular defects, the pre-existing vascular defects like either dilatation at that part, aneurysm-like conditions, or maybe some other previous reasons where the vessels might have been damaged as such. Subarachnoid is when the bleeding occurs into the subarachnoid space, and most of the times the subarachnoid conditions would be a result of the trauma. Once there is a trauma and the blood vessels in the arachnoid space, subarachnoid space, they tend to get ruptured, and the vessels in the subarachnoid space, they tend to get ruptured during the trauma because of the susceptibility. Susceptibility is on the one side there is the skull bone, or on the other side you have the durameter, which is somewhat elastic, and because of that kind of a relationship or vessels being in between an inelastic and elastic surface, they are more prone to get damaged and bleeding could occur. The clinical presentation of a intracerebral hemorrhage is onset is usually catastrophic. Catastrophic in the sense because the bleeding occurs, blood mixes with the cerebrospinal fluid, the whole surface of the brain may get irritated, and hence the patient would have a very severe symptom. Onset would be presenting with a severe symptom. Often the patient would have a high degree or a high level of the stroke score. Stroke score, I'll come to that later. And often the patient may even have impaired consciousness. Consciousness is often impaired in that condition. So during the onset, things seem to be very critical. But once the hemorrhage has been stopped, usually, like when I say use this, I use the word usually. Usually, the patients would recover rapidly because once this bleeding has stopped and the irritation of the nerve cell in the surrounding area has been reduced, it's only that area of the brain which has got damaged which would produce the clinical symptoms, and hence the hemorrhagic stroke would always have a catastrophic onset and a relatively early recovery. Thrombosis patients, it's a gradual onset and a progressive course. Embolism, a sudden onset but localized features. This is the primary classification of the stroke which we identify and the important from the clinical point. Subarachnoid hemorrhage is usually accompanied with a lucid interval. Lucid interval in the sense, suppose a patient had a trauma, immediately after the trauma, there may not be a neurological symptom or maybe a neurological symptom of minor degree, and then after a certain period of time, which could extend from a few minutes to few days even, the patient may develop the symptoms as such. That interval between the trauma and the onset of the nerve these neurological symptoms is what we call as the lucid interval, and that's a characteristic of the subarachnoid hemorrhage. Now, once a patient of stroke comes to you, it's quite important to assess the level of the stroke before we go into the real causes, because a patient coming to you with a recent history of the stroke, this is all relevant in the patients who are having either the transient attack or the progressive course as such. If a patient has become stabilized, static, this score is not very critical. But if a patient comes to you in the immediately after the stroke, the important points which you have to assess, and there is an international scoring method, and that scoring method has to be followed, and the scoring would be based upon one, the level of consciousness, and the level of consciousness again the scores could be from 0 to 3, and the orientation questions, like you may ask the patient about his age, name, and or surrounding area. You might have seen in the rounds, during the rounds, you usually ask questions like the name of the patient, from which place they come, and that gives you the score. The score would be 0 to 2 depending upon the correct answers, and the patient obeying the commands, whether the patient can obey the commands or not, like open and close the eyes, or maybe move these move some limbs as such. So, whether the patient can follow you or not, again the score would be 0 to 2, and whether the patient eyes open, and then whether the patient can follow the fingers or the face of the physician, like that's whether they can really have a proper gaze or not, and that again you will have the score of 0 to 2. The visual fields is another issue. Visual fields, if there is a impairment of the visual field, then the patient would the score would be again 0 to 3. Whether the patient has a facial paralysis or not, that's another issue. Then the motor symptoms, motor signs, whether it's unilateral or bilateral. If it is unilateral, left and right, you will have a score from 0 to 4 as such. If cannot be tested, like a patient who has some abnormality, then usually the score is X as such, and you will be giving the scores separately for the left and right. So, if the patient has bilateral, the score could be up to 8, and if the patient has a patient is able to move, but there is a ataxia, the patient is not able to coordinate the movements, like the usual tests which is done, finger nose test or heel down tests, like again the score is 0 to 2. Sensory, if there is an impairment of the sensory, again the score can be assessed. Most of the times you will not have sensory abnormalities in the patients whom you see. They are relatively less common. Motor symptoms are more common in a patient of stroke, and whether the patient can identify the object and speech which is absolutely relevant, and exactly read the sentences, describe a picture, and so on, which we consider as a level of consciousness, as such a perfect level of consciousness. Then again the score will be 0 to 3. Dysarthria, where the patient is not able to form the language or form the words as such, then again the score will be 0 to 2. And of course, a dysarthria cannot be evaluated if a patient is already in a intubated condition, so that it's not relevant. And if the patient has a having this intellectual inactivity, extinction, like the patient is not giving an attention to whatever you are seeming to be irrelevant, conscious but not relevant as such, then again the score will be 0 to 2. This way you may have a scoring, and depending upon the score, you can select whether you can treat the patient or not. A patient with the 5 to 15 scores are considered as moderate score, and such patients can be managed without a life support. And when I say without a life support, simple support techniques like rail tube or maybe catheterization is not considered, but the patient may not require a ventilation or maybe a tracheostomy tube, etc. If the score is more than 16, in between 16 and 20, then that's also a very severe stroke, and in such conditions, the condition will be critical. Patient may require a life support as such. If the score is above 20, then it's a highly critical, outcome would be poor. So, from the point of view of selection of a patient, like if a patient comes with a recent history of the stroke, whether we can treat that patient or not. In our setup, like hospital setup, I generally do not prefer to take a patient with above 15 score, maximum 15 or maximum 20, not beyond 20 at all. If the score is more than 20, definitely I will be referring the patient to some other hospital so that the facilities offer that essential life support, ventilation, or maybe the tracheostomy they may be provided. Now that's one way of assessing. If the patient is not conscious, then the Glasgow Coma Scale is another important critical issue. In a patient who is conscious, Glasgow Coma Scale is not relevant. But if the patient is not conscious, Glasgow Coma Scale assessment is important. And in the Glasgow Coma Scale, if the score is less than 8, then essentially the patient requires life support, which again is quite difficult to manage. So the first of the thing in a patient of stroke, particularly evolving stroke or progressive stroke, is to assess the severity and decide whether we can manage or not. And once we have decided that, so the approach to the management would be, the first approach is you assess and maybe confirm whether we can treat that patient or not. If we can treat that patient, then the target of the treatment would be, in any patient of stroke, as I said, the clinical symptoms would be, part of the symptom would be produced due to the dead tissue, irrespective of the cause, like whether it's a hemorrhage or thrombosis. But the other important critical issue is the involvement of the peripheral area, which we call as the penumbra. This penumbra area, the tissues surrounding area would be having a impairment of the function, and there is always a risk that these nerve tissues may get damaged, and hence the target at that condition would be to prevent the damage to the nerves. So first target is life support to ensure that the patient is kept alive. The next target is minimize this damage to the peripheral nerves. To minimize the damage to the peripheral nerves, there are many choices of the treatment, like the glucocorticoids, which you usually prefer. Like you have seen in many of the patients, we give dexamethasone in the immediate state. So dexamethasone is one of the means by which you can minimize the damage to the nerves. You may have the other involved treatment. The other is the clot buster treatment, streptokinase or streptokinase injection, which we do not usually prefer in our hospital. In some other sophisticated hospital, a streptokinase or streptokinase can be directly injected through the vessel, or maybe attempt to open the clot busting treatment. These are all the options by which the whole target of that would be to minimize the damage to the surrounding area. Once the nerve tissue is dead, of course, if it's dead, it cannot be recovered. The target would be to minimize the damage to the surrounding area so that the damage is lesser. That's the next target. Investigations, as I think we have discussed about these investigations in the radiology class again. But again, the important is if the patient has a ischemic change, the ischemic changes may not show the results immediately, and the choice of the investigation is always MRI. MRI is always a better choice than the simple CT, and a CT also could be quite good enough. But in the initial stage, up to about 24 to 72 hours, the onset, the ischemic changes may not be visible in the imaging studies if it is a moderate ischemia. Of course, in a severe ischemia or in a hemorrhage, the symptoms could be seen or the changes could be seen immediately. So, wherever there is a possibility, it's better to postpone that CT or MRI image to at least 24 hours or 48 hours, so that you will not have a negative image or negative results. Of course, the choice whether you do it immediately and then again repeat it after 72 hours. These are all the issues of the practical handling of the patient. But important is the features which you observe in a imaging study done immediately after the stroke, they are not totally dependable. A dependable feature or assessment of the condition could be done if you repeat the imaging study after about 72 hours. And the features could be as either it could be hypoattenuation of the brain tissue, or it could be the nucleus, which could be necrobus as such. So depending upon the location, the severity of the condition could be assessed. And if it is involving any vital centers, like respiratory centers, vasomotor centers, then the patient may be in a very critical condition. So another important part of the management would be, you will have to assess the area which is involved, and the extent of the damage which is involved. Now, once this is done, then the treatment protocol. Now, when I say this, in the all stroke conditions, in the acute stroke conditions, which may not have, we may not have, from analytic point of view, we may not have such a issue options where the pathology can be immediately reduced. The time is an important factor. In the acute conditions, when there is a penumbra damage, that the tissues around the area, the reducing that damage is the important issue, and that time is a very important factor. And I don't have any definite Ayurvedic option of preventing that. In such conditions, one target would be ensure that the blood pressure is normal, and then the other is which we usually prefer would be glucocorticoids. If the patient is in some other hospital, you may have the other options. Of course, if there is a hemorrhage, then or edema, brain edema as such, edema can be reduced by the diuretics, osmotic diuretics like mannitol, which also could be one of the options. There is the edema can at the surrounding area can be protected to a certain extent. So those options are to be followed. And then the other part is about the life support like relative feeding or catheterization or oxygen supply, so on. That's another part. Now, once this is done, then the next part of our management, Ayurvedic management, the other is management of life support and other issues may not be relevant in a static stroke where the patient has already been stabilized. In such conditions, we can directly go into the assessment as such. And the assessment will be based upon whether the patient is in a flaccid paralysis stage or spastic stage, or in a very downstream stage, atrophic stage. Flaccid paralysis stage is usually suggestive of usually seen in immediately the short duration of the stroke, and that's evidence of a avarta vata. When there is a avarana vata, avarta vata, and there you need to have a pachana chikitsa. The description of the stroke mentioned here as the pakshaghata in case of the Charaka Samhita, the important is patati, tata patati. When the patient is not able to sustain the movement, limb as such, that condition is considered as the flaccid paralysis, which requires a treatment of pachana chikitsa. Whereas the description of Vagbhata, the other stages of the Pakshagata also mentioned, and the other stages could be, one is there could be Snayu Vishoshita, where there could be an atrophy. Atrophy could be seen usually in the very advanced stages. Say a patient having a stroke for a quite a long period may have atrophy of the muscles, and the patient may even have a spastic stage. Most of the times, the spastic stage occurs within 2 to 3 weeks of the flaccid paralysis. The time taken for the flaccid paralysis would be a decisive factor. The flaccid paralysis, if the time is shorter, the damage to the peripheral, this penumbra tissue would be lesser. So surrounding tissue and its damage, recovery from the damage can be indirectly assessed by the duration of the flaccid paralysis. Once the patient reaches the spastic paralysis, that means the stroke has stabilized, and I consider that as the Kevalavata Vyadhi. So a avarana and the niravarana condition can be assessed that. Of course, during that stage, you can decide exactly like whether any specific part, Ekanga Roga or Sarvanga Roga, is identified. Because in the flaccid paralysis stage, your clinical assessment might not be very accurate. Localization may not be very accurate. But once the patient reaches the spastic stage, this would be very accurate. My prescriptions usually would be in patient of all Vata Vyadhi, particularly where you expect a Dhatu Kshaya, like in conditions of hemorrhage or maybe the ischemia, there will be Dhatu Kshaya as well as Margavarana. My prescription would be usually Abhraka Vasma Tapyadi Ekangavya. Abhraka Vasma Tapyadi Godanjay, which is the very common prescription in all such patients, and Ekangavya. The other part of the management is depending upon the flaccid paralysis, which is considering whether they say Avarana Janya or the without Avarana. And in the flaccid paralysis stage, it's the Agni Chikitsa and Matravasti, which you have seen in plenty. Whereas in the Niravarana stage, spastic conditions, it's the Pindasthira and Matravasti, or Raja Pindasti in the atrophic stage. The outcome in case of ectropic stage is very poor. Once the patient has attained the ectropic stage, the outcome will be poorer. And in the other conditions, the outcome can be better, provided the patient's the other complications are prevented. The common complication is hypertension. So antihypertensive drugs are usually prescribed. And another is the platelet aggregation inhibitor drugs are also to be prescribed. But in all the patients, evaluation of the cardiovascular system is necessary. If there is a cardiovascular system pathology, that also needs to be handled depending upon the patient's presentation as such. So that's about, in brief, about the stroke as such. Now, the stroke also could be considered this description of hemorrhagic stroke also is mentioned in Sushruta, when the symptoms would be like Raha Sandapamurcha, that a global symptom, that sign of hemorrhagic. When it is relatively milder, then it's a ischemic stroke. And when there is a space occupying lesion producing the stroke, that's considered Shuddhavata, which is considered Asadhya, Kebalavata. Or toxic strokes also are mentioned, Garbini, Sujika, Bala, Vrindakshina. So these are all the toxic stroke conditions where the condition could be very difficult, and the approach to management also is different. We will not go into that part. Toxic issue, this toxemia of pregnancy or postpartum toxemia, that's another condition where the principle would be totally different. But one of the important issue is Kevala Vatajanya Vyadhi. Once you have reached that stage of Kevala Vatajanya Vyadhi, the outcome would be poorer. That's in brief about the stroke and its related issues. The next part which we discuss would be the Parkinson's disease or patients presenting with the tremors. The Parkinson's word itself would be somewhat confusing. You will have Parkinson's disease, Parkinsonism, and Parkinson plus disease. These are all the common words used. When we say Parkinson's disease, it's about specific about the pathology where the neurotransmitters are not sufficient, or the neurotransmitter like dopamine, the deficiency occurs in the extrapyramidal area, and hence the lesion has occurred. When we say the Parkinsonism, it could be an extrapyramidal lesion which is produced due to any other condition like ischemia or maybe a space occupying lesion, or it could be due to the drugs, toxic substances. Drugs producing a Parkinson-like symptom is one quite important. A Parkinson plus is when the patient has a very rapid course of onset and usually presented with the more severe psychiatric symptom. That condition is called as Parkinson's plus. So that's about the categorization as such. But practically, from the clinical point of view, when we deal with the ayurvedic management point of view, this kind of differentiation may not be very critical as such, like whether it's a Parkinsonism or Parkinson's disease is not important from medical point of view. But from the practical clinical point of view, Parkinson's disease would respond to a dopamine replacement, the usual common prescription Syndopa, and the patient would respond better. If the patient has other pathologies like ischemic conditions, dopamine replacement may not produce satisfactory results. So most of the times, the patients who come to us Ayurvedic treatment, they are of that category where the Syndopa has failed to produce the results. If the Syndopa produces satisfactory results, the patients may continue with the coexisting treatment. So from Ayurvedic point of view, Parkinsonism is more common, more important than the Parkinson's disease. When I say this, it's exclusively considering from Ayurvedic hospital point of view. Anyway, a typical Parkinson's condition, both whether Parkinson's syndrome or the Parkinson's disease, presents with the typical clinical symptoms of tremor and the finer movements being affected, subtle decrease in the dexterity. Like when I say that, patient may find it difficult to do very fine movements, like it starts with the fine movements like threading a needle to writing and so on. Changes in the voice, a facial expression being decreased, sleep disturbances, behavior abnormalities like sudden loss of tone in the muscles also could occur, sense of smell being decreased, automatic dysfunction like constipation, sweating, sexual dysfunction also could be the initial clinical symptoms. Occasionally, the dermatitis could be the clinical presentation of initial clinical presentation of the Parkinson's disease, a general feeling of weakness, lassitude, depression, or even slowness in thinking. It could be intellectual asset. In a typical Parkinson's disease, typically the symptoms will be asymmetric, like it could be more on one side than the other. And the most common initial finding is resting tremor and in the upper extremity, the most common in the hands, tremors in the hands, and that too, which can present in resting condition. And it's typically pill rolling type movement, repetitive movement with others. Then, of course, the patient may have bradykinesia, rigidity, gait, as such. So, you have seen many of the patients that abnormality of gait. The typical posture also is common. So, that's about the typical course of Parkinson's disease. Parkinson's disease, as such, is usually a slowly progressive condition, and the symptoms could gradually extend depending upon the area involved. When it's a relatively minor area, gradually it's the lesser area of the amygdala is involved, then the symptoms will be milder, then gradually it increases, and hence in a typical, and when the neocortex or the superior cortex is involved, then the patient would have more of psychiatric symptoms like depression and so on. And this kind of a categorization is important based upon whether you are going to treat that patient with a symptomatic antipsychotic drugs or not. From dopa replacement or dopamine replacement would be good enough up to the stage of the fourth stage, early symptomatic stage. Fifth stage and sixth stage, the muscle rigidity is more common, so hence you will have to give drugs which will reduce the rigidity, like Pacitan, or patients may require a support to the psychiatric symptoms also. Antipsychotic or antidepressant drugs could be needed. From the clinical point of view, in addition to the Parkinson's disease, a large number of patients whom we see are produced due to drug-induced abnormalities of the movement is another very common condition, and from Ayurvedic clinical point of view, these are important. To take the history of the drugs taken by the patient in a patient with the neurological pathology, particularly where the patient has an abnormality of the movement, is quite important. Those patients who have a Parkinson-like condition, which is pseudo-Parkinsonism, I think whatever we have discussed earlier, the tremors and the typical condition, the common drugs which are produced are which are seen are one is antiemetic, major group of antiemetic drugs. They can produce these symptoms, and then the anti-epileptic, particularly valproic acid. Then cardiovascular drugs, Diserpine, when I say this, including our Sarpagandha tablet, is known to produce this symptom. I have seen plenty of patients who are prescribed Sarpagandha in high doses, developing the symptoms as such. Then most important, still very critical important is psychotropic drugs. Many of these, and among the psychotropic drugs, haloperidol and clonazepam. These are very commonly producing these symptoms as such. And of course, even tetrabenazine, which is used as a antibiotic drug, occasionally anti-helminthic drug, also can produce pseudo-Parkinson conditions. Then, in addition to that Parkinson-like symptoms, you may have the other signs, other neurological deficits or movement abnormalities due to the drugs. From the clinical point of view, these are important because patients coming to you with the dystonia, where the patient dystonia is presented with the upward, involuntary upward movement of the eyes, and maybe the grimacing face becomes just very tonic-like, and the muscle spasm tend to occur in the tongue, face, etc. Or even there could be spasm of the larynx. The common drugs which can produce these are droperidol, prochlorperazine, which are considered as antiemetic groups, and psychotropic drugs, particularly haloperidol, which is and even clonazepam. This can produce both either Parkinson-like conditions or dystonia, acute dystonia could occur. The importance of this would be if you can identify the drugs as being the cause, you can manage that patient better, outcome would be better. And another sort of abnormality is akathisia. Akathisia is a patient may feel restless and just moving around as such. and the patient may have a trouble in standing in a position or maybe in a static position. They tend to move the limbs and so on. So that kind of akathisia also could occur due to similar drugs. Exactly the same drugs can also produce a similar drugs. And among the anti-epileptic is a carbamazepine, which is usually given in petit mal epilepsy treatment. And among the psychotropic drugs, lithium. Lithium is one of the very commonly prescribed drugs in psychiatric condition due to the lithium deficiency. And in that patient, such conditions, akathisia could be the symptoms as such, or it could be the dyskinesia. Dyskinesia, where the patient may have a rolling of the tongue or protrusion of the tongue, etc., or continuous movement like sucking of the movement of the mouth. You have seen such patients quite frequently. And among these, the very important is patients who are on peptide drugs and epileptic drugs, where withdrawal could be difficult. So important is that in these conditions, a detailed history about the drug intake and a possibility of the drug releasing these symptoms should be assessed. Next part is whether you can really withdraw those drugs or not. Some of the drugs can be easily withdrawn. In some other drugs, the withdrawal will be difficult, which is a very difficult issue to decide. Now, once we have done this, the approach to the management would be, I consider the patients of Parkinson's disease as most difficult conditions. Outcome would be always poor. From Ayurvedic point of view, the results are usually poor. Though often the people use the word Sarvangavata. Sarvangavata word is not really describing the text as such. Instead, Sarvanga Kampa is one of the symptoms mentioned, and it's also named as Vapor. There is no curative treatment. So in all the patients who are on Syndopa or such drugs, I would not withdraw those drugs. But if at all there is a possibility of withdrawing those drugs which can trigger these symptoms, that's one of the important options by which you can produce a result. Otherwise, the results are very poor, and my approach to the treatment is same discussion would remain same. But because I consider this as Kevalavachajanya Vyadhi, I always prefer Tailadhara or Rajapanga Subramana Chikitsa. Last of the condition which we discuss about the neurological issues would be the seizures. Now, a patient presenting with seizure could be produced due to many causes, and it's quite important to understand the causes. Every case of seizure is not epilepsy. Epileptic seizures, where you will have the typical aura and then the presentation and such, could be produced due to large number of causes like drugs, metabolic, infectious, structural, and systemic. These are important. Non-epileptic conditions like syncope, neurological, so these need to be ruled out when a patient presents with a history of seizures. From the clinical point of view, it's quite important to make out. From the practical clinical point of view, the quite important to make out would be the structural, where there is the organic pathology of the brain, and the focal, where there is no specific organic pathology of the brain, which will be typically categorized as epilepsy. The other conditions, like suppose patient has a electrolyte abnormality, that has to be replaced. So I would not consider this as epilepsy and the treatment of the epilepsy as such. So we will rule out these conditions, but a patient presenting with a seizure, a relevant investigation is quite important, and that's the issue. Among those structural pathologies which produce the patients who have developed ischemic stroke or hemorrhagic stroke, where there is a organic involvement of the brain tissue, they constitute a huge category. And from our clinical management point of view, from my very clinical management point of view, most of the patients who had developed stroke once, they tend to have a epileptic focus, and that area of the nerve damage could be acting as epileptic focus, and they are the ones which we have to treat them for the sake of the epileptic symptoms. Then, of course, neoplasia, Alzheimer's disease, are the other conditions. From our practical clinical point of view, these are important issues. Then another category of the patients whom we see would be the febrile seizures, particularly in children. Patients when they have a fever and the fever is more than 103 degrees Fahrenheit, then there is a possibility of having the seizures. There, the criteria of deciding whether the febrile seizures have to be considered as simply a consequence of the fever or whether the patient requires a treatment for the epilepsy would be based upon one, whether the patient has an attack lasting for more than 15 minutes or not. If the attack is lasting for more than 15 minutes, or if the patient has more than 2 episodes in 24 hours, then that patient has to be considered as a possibility of epilepsy and the anti-epileptic treatment is required. If it is not, if it is less than that, then it could be simply considered as a febrile pathology and a simple febrile seizures can be managed as it. So that's the criteria. Of course, the other investigations like the blood glucose level and then maybe CT or maybe lumbar puncture, they may be necessary to confirm the diagnosis in such conditions. That's one way of assessing. Another way of classifying a seizure patient would be, of course, in the older term, we used to say the term like grand mal epilepsy, motor epilepsy, and then petit mal epilepsy. The current non-terminology is for petit mal is the focal, and then grand mal generalized onset, and the motor, of course, unknown onset or motor epilepsy as such. These are the words which are used. Of course, that's it. Only the question of difference. The important is in a grand mal epilepsy, there will be an aura, and the patient would have a tonic and clonic phase as such. And then after the epileptic seizure, there will be a duration where the patient would have some these sleep like state. So aura where the patient can feel the symptoms and that he is going to have the attack. And then during the attack, there is a tonic phase where the muscles will be under tone and the patient would be essentially losing the consciousness. That's the grand mal epilepsy or generalized onset. In the minor or petit mal epilepsy, there could be either a sensory, like where the patient may have temporarily behavioral errors or temporary impaired consciousness, or it could be fine tremors like spasms or abnormal movements. A typical motor epilepsy, a Jacksonian epilepsy, could be having a repeated movements in the same area. Now, these can be considered as a apatantraka or apadanaka. The description would be mentioned in the text as such. And all those clinical presentations, variations like dandapadanaka, where there will be persistent rigidity, where there could be a epistatonus or the endochronus, antarayama or bahirayama, these also can be made out. A tonic phase and the clonic phase, these are described in the text thoroughly. Now, leave alone that textual description. From the clinical point of view, my clinical experience with these seizures are febrile seizures, trigonokirti and saraswaris are given for a considerable long duration, can effectively prevent this, and you don't need to have any other anti-epileptic treatment. If the patient has a focal epilepsy and the patient is on anti-epileptic drugs already, I do not withdraw those drugs. Along with those drugs, I usually prescribe Smithsagarasa or Kamaduga or the Ekangvira or maybe all of them together, depending upon the patient's presentation. Sarsavarisa is a common drug which is prescribed. Tailadhara, Yapanabasti and Anutelanasya are the other prescriptions. A general guideline is if the patient is on anti-epileptic drug, do not withdraw that. And the treatment to be continued till event-free 2 years. Now, my criteria is about 2 years. Other criteria is 5 years. With our treatment, if you can achieve a period of event-free 2 years, then the contemporary drugs, like maybe anti-epileptic drugs, they can be either tapered or withdrawn, and that's possible as such. And in secondary epilepsies, like patients who have a stroke and then develop the epilepsy, or such where there is organic damage, withdrawal of the drug is virtually not possible. Then febrile seizures can be effectively prevented in almost all cases. About 50% of the recently diagnosed adult focal epilepsies can be managed successfully without the anti-epileptic drugs. Whereas dosage of anti-epileptic drugs can be reduced in about 60% of the patients. This is what I have seen with the following line of treatment. But if you ask me like what's a very standard treatment for the epilepsy, I don't have a definite standard result treatment for the epilepsy as such, but it can be safely prescribed. Another common prescription which is often done now is about the ghritas, different varieties of the ghritas. It is Panjatik Ghrita, maybe the Paishatika Ghrita, and so on. Now, a Ghrita prescribed in epilepsies can produce the results. I have seen that only when it's given in the Prabhuta Matra. Prabhuta Matra in the sense, it has to be given for a short duration, not more than 1 week. If at all need that, you may repeat. But giving Dhruta every day, like a 2 teaspoon or 1 teaspoon every day, would not produce the results. This is what I have observed. Now, last part is epilepsy is also a issue which is related to the law. There are many important laws which you have to know when you deal with a patient of epilepsy. Earlier days, epilepsy was considered as a enough reason for a divorce, but since 1999, this clause is removed. Many people do not know about it. I have just taken into this issue because many people do not know that, and if at all you give a certificate about that, suggesting like a patient has an epilepsy and hence divorce can be done, you are wrong on the wrong side of the law now. So from December 20th, 1999, the law is changed. Many of the older textbooks may still have that clause sentence like it could be a good cause for invalidity of the marriage, but that's not true now. Then patients who have post-head injury fits or epileptic convulsions can produce a permanent damage to the locomotor system, and hence those patients have to be considered as a very careful asset. Then epileptic students can be exempted from studying the third language. This also is important. And a treatment for epilepsy, if at all any money is spent there, it can be deducted in Income Tax Act. So if you have a patient of epilepsy in the family and you have the records of treating that patient, the expenses can be exempted from the Income Tax Act. These are certain of the important laws, and driving license cannot be issued to an epileptic. That's about brief important things which are related to the epilepsy asset. With this, we will conclude, and to have a complete list of all neurological conditions is practically not possible. I have tried to make out those conditions which are clinically important. So we will conclude about the neurological conditions. If there are any questions, I will try to answer, and then I think we'll. Sir, when the stroke happens, how do we know whether it is a progressive or not? It's by only a regular assessment. You have to examine the patient, and periodically you have to examine, like once in an hour or once in 2 hours, or maybe in a day. If the area of involvement, the neurological signs are extending, that's suggestive of an expansive progressive stroke as. And usually the progressive stage is up to about 48 hours on an average. Up to about 48 hours, the stroke would be progressive. It's a usual, but in some patients, the progression can be quite longer period also. Then same patient has a repetitive stroke. So okay, repetition up is another issue. A patient who had a stroke and then maybe seeming to be recovering may have another episode of stroke. That depends upon the other causes which have triggered. So that again you need to assess them. Then Virechana and Abhyangalepa. Virechana, Pakshagate Virechana, the treatment line is suggested in textbooks, but Virechana I would prescribe only in the spastic condition, not in the early condition. And what I have observed is in the spastic condition, Pindasveda like treatment would be much better than the others. So I rarely use Virechana as such. Condition is helpful in ischemic or hemorrhagic. So to say like whether Virechana helps in ischemic or hemorrhagic condition, I don't know. I can't say that. But I would not prefer Virechana in the flaccid stage, in the Samavastha, in the Niramastha only I prefer. Then degenerative dementia be corrected. Okay, all right. Among the neurological conditions, one of the conditions which we have not really discussed is dementia and Alzheimer's. So dementia and Alzheimer's, once there is a neurological damage, nerve tissues are damaged, virtually that cannot be recovered completely, but there can be a better clinical outcome. We have plenty of patients where patients have shown a significant relief. Patients have a better quality of life, but I don't say that any of the patient is cured. So there is no question of a cure for degenerative dementia of any sort, but conditions can be improved with the usual same treatments, and Thailadhara, Rajayapan Basti. Some patients may respond as such. So Rajayapan Basti is one very dependable treatment, and Dhara treatment also, which can produce some benefits in such patients. I don't say that the patient can be cured. I think that's about the one more of question. Uh, then main difference between convulsion and no, convulsion and seizure are the same. Words are different. They mean the same. Convulsion and seizures word, the meaning is same. So there is no differences. Right. There are no other questions. So, okay. We'll wind up. Thank you.
Thank you, sir.